So hello everybody. Don't miss out on this in the initial ABCD approach of the trauma management. What is important is one is that how do you manage the airway? Breathing, you need to understand about the intubation, laryngeal mask, airway, cricotothyroidotomy. How do you secure the airway? Circulation and everything is obviously the fluid of choice and the inotropic support and the classification of shock, which you asked in this question. That is the classification of shock on the basis of blood volume loss, the vitals, blood pressure, pulse pressure, respiratory rate. So don't miss out on this very important things from trauma portion, because this would be very straightforward questions. So classification, we all know it is similar everywhere, so you don't need to get confused in it. But what is extra given in Sabiston is regarding the classification according to the base deficit. Okay. So if you have base deficit of 0 to -2, that is class 1, okay? Then if the base deficit increases to -2 to -6, it is class 2. From that, if it more increases to -6 to -10, and if it goes below -10 or less, then it becomes class 4. So this is something which is extra. You need to remember that even according to that, the classification may change. So other than that, the heart rate, the respiratory rate, the GCS and everything is important. So don't get confused in the classification and try to remember the classification in very much detail. Next, most important is tag. We have been asking in almost everywhere, wherever tag is important. So you need to be very thorough with what are the components of tag, how do you manage with the various results of tag. So if we understand, if I'll revise again, what are the components? So one would be the R time, okay? Then comes the alpha angle, then comes the maximum amplitude, and then comes the LY30, okay? So these are the various components. If you see the graph, that is how you will understand regarding the tag. So till the clot formation starts is the R time, the speed is measured by the alpha angle. The maximum clot strength is measured by the maximum amplitude. And the fibrinolysis at 30 minutes and 60 minutes is given by LY30 and LY60. So you need to be aware that what are the components. Okay. Now what we've asked is that we have given a patient with a prolonged R time. Okay. So that is important in terms of what does it denote. So if it is a prolonged R time, that means that the clot formation is delayed. That means that there is deficiency in the various clotting factors. There is a decreased maximum amplitude. That means that the platelets and fibrin and everything are not adhering and the clot strength is not that much. So that means that there is some platelet deficiency and there is increased fibrinolysis that is showing by increased LY30. So how do you manage it? So you need to basically identify the coagulation abnormalities, that is delayed clot formation by the prolonged R time, platelet dysfunction, increased fibrinolysis. You treat each with plasma transfusion, you give platelets for this, and you give tranexamic acid for this. So hence B is the answer in this. So do not get confused in tag. Go through and read again. Tag is very important and even very simple if you understand the basic concept of the graph. What does it denote? Okay. Next, patient with a severe traumatic brain injury. There is persistent intracranial hypertension. What should be followed? So this is what has been given in Sabiston. So again, yesterday also what I told was that EDS, SDH, everybody knows, everybody will be able to answer them. But what is important is the other portions of the traumatic brain injury and its management. So if you see in Sabiston, what they've given is they've given a 3-tiered approach of the management. So what does the tier 1 have? So the tier 1 in the management of severe traumatic brain injury has 3 tiers, that is tier 1, tier 2 and tier 3. So tier 1 is basically showing that you need to control the pain, that is by an adequate analgesia. Okay. Control the pain. And if at all there is an increase in the ICP, you drain the CSF, okay, by doing a EVD or a ventriculostomy. Then comes the second line management or tier 2, that is giving a hyperosmolar therapy like mannitol to reduce the edema, and you may consider some neuromuscular paralysis. And lastly, to If even after all this, still the patient is not responding or deteriorating, you may need to reduce the brain metabolism by either giving hypothermia or putting the patient in coma by barbiturates. You need to basically cause a therapeutic vasoconstriction so that there is reduction of the fluid edema that is done by maintaining the PCO2 between 30 to 35. Okay. So these are the three-tiered approach. One is simple, starting with simple analgesia, anesthesia, and ventricular drainage. Second is giving hyperosmolar therapy to reduce the edema. And third, if at all it is not helping, then try to decrease the brain metabolism. So you decrease the brain injury. In traumatic brain injury, like in spine, there is no role of corticosteroid management. So do not get confused anywhere such question is asked regarding corticosteroid. Okay. So, which is considered ineffective. So, if you go according to the tiered approach, you first consider neuromuscular paralysis, then hyposmolar therapy. So, B is incorrect or ineffective. Barbiturates can be given, sedation can be given. But here you cannot use corticosteroid. So D is ruled out. Okay. So basically, yeah, coming back to this question. So we have asked regarding what tiered approach should be followed next for management in this patient to control his ICP, and which intervention is considered ineffective for traumatic brain management. So here basically if we see, B is the answer. Why? Because as I said, you reduce the edema by giving hypertonic saline or mannitol. You consider giving neuromuscular paralysis. So, but this will help you to reduce the edema. Neuromuscular paralysis and repeat CT imaging is also considered in the tiered approach. So B becomes the answer. Elevation of head and administering corticosteroid, as I said, there is no role. So A and D are automatically ruled out. To rapidly reduce the ICP? No, they are not done to rapidly reduce the ICP. So using barbiturates and significant hyperventilation are done at the end to reduce the brain metabolism and not to reduce the ICP. So obviously C cannot be the answer, hence B is answer in this question. Next, cervical cord injury, neurogenic shock, hypotension. Yesterday also we have discussed that basically what is the immediate management in this condition and about corticosteroid use. So corticosteroid, no role. Next, you cannot allow brief period of hypertension. You need to immediately control the hypertension in such patients. Next, aggressively treat hypertension with volume expansion and vasopressor. Yes. And if at all you want to give, you should give within 8 hours of injury. So that is the correct option. So remember that in cervical spinal cord injury, one is that any hypertension will exaggerate the trauma which has happened because of the hypoperfusion. So you need to immediately take care of the hemodynamics in any patient with neurogenic shock. You need to maintain the mean arterial pressure in the range of 85 to 90. Okay, that is important. Next, what is important in this corticosteroid therapy? It has been considered that if you want to give, it may be helpful in the initial 8 hours, but after that, there is no difference after in the later on period after 8 hours in the 24 or 48 hours, there is no difference. So it is not considered. Okay, that is two things which is important to understand. And third thing, how do you manage neurogenic shock? You manage with the help of fluids and vasopressors. That is also what we discussed yesterday. Okay, so these are few concepts regarding neurogenic shock and spinal cord injury. Now coming to the particular fractures and their treatment. So if you see, this is from the table which has been given regarding the fractures and its management. So if we consider C1, that is a Jefferson fracture, you manage if it is a stable, any cervical fracture ranging from C1, odontoid, C2, anything which is stable will be managed with a hard collar. And if it is unstable, you manage with the help of traction or you need to go for surgery. Okay, because these are very sensitive areas, so you cannot just manage conservatively. So C1, Jefferson fracture, stable hard collar, unstable surgery. Odontoid tip, or if it is only through the tip of the odontoid. So if you consider odontoid fracture and it is from the tip, you just go for management with a hard collar, okay, because that will be stable. But if the fracture goes through the base or the body of C2 vertebra, then you need to manage with the help of hollow vest, or depending on the stability, consider surgery. If we consider hanging fracture, that is complete fracture of the C2, you need to consider hollow vest if it is stable, and surgery if the displacement is severe. If we come to the cervical, thoracic, or lumbar vertebral fractures, cervical, usually if there is not much difference in the height between the two vertebra, then you consider conservative. But if it is involving multiple columns, so if we see the concept of columns, there is a anterior column, there is a middle column, and there is a posterior column. So if the injury is more than 2 columns, okay, then it is considered as a unstable fracture and you need to go for surgery. If we consider thoracic and lumbar, in both of them, if it is injured the anterior, you only go for a orthosis, that is immobilization. And if it is involving anterior and posterior, you go for surgical stabilization. Next, moving on to the next question, that is penetrating injury to the neck. Hemodynamically stable, but difficulty swallowing and hoarseness. Okay, that is an indicator of something. There is no hematoma, active bleeding. There is some subcutaneous emphysema. CT scan is done, which is not showing any vascular injury, but air is there around the esophagus. So what will you do next? You cannot directly export. You cannot observe because there is some air in around the esophagus, and you cannot do a DSA because there is no vascular injury. So obviously, as it is around the esophagus, you need to do a esophagoscopy and a bronchoscopy for identification of either injury to the respiratory system or the esophagus or any development of any fistula. Okay. So that is why it is very important. First, remember what are the zones of injury in the neck. From the thoracic inlet to the cricoid is zone 1. From that to the angle of mandible is zone 2. So if we consider this as thoracic inlet, this is cricoid, this is angle of mandible, then anything between this area is zone 1. Between this is zone 2. And above the angle of mandible to the base of skull is zone 3. And what is important to understand is that you need to understand if there is any hard sign of vascular or aerodigestive injury, because in that cases you will need to do a surgical exploration. So what are the hard signs? Any expanding or pulsatile hematoma, any active bleeding, any massive subcutaneous emphysema, any air bubbles, everything is you need to rule them out properly and then consider going for a surgical exploration or going for a conservative management. Okay. So if you have any doubts, please let me know in between so that I can address them. Next, there is a gunshot wound, stable, again, same hoarseness and mild subcutaneous emphysema. Expanding neck hematoma, so that is a hard sign of some arterial injury, okay, already given. There is a focal neurological deficit. It is between cricoid cartilage and the angle of mandible, so it is in the zone 2, okay. So directly B becomes the answer. And which of the indicators suggest high risk of blunt? So it contains carotid and vertebral arteries and jugular veins and structures of aerodigestive tract. That is also very important, that which zone contains which structures, because accordingly we need to go for a conservative management or a surgical management. So all the findings given, that is expanding neck hematoma, focal neurological deficit, everything is a hard sign of vascular injury needing surgical exploration. Now, which are the structures there in zone 1? So in zone 1, you are having trachea, esophagus. In zone 2, you are having carotid, vertebral artery, jugular veins. And in zone 3, you are having the vertebral arteries and the cerebral arteries, which supplies the brain. Next, a patient with a GCS of 5, okay, severe mid-face fractures with Lee-Ford 2 and 3, significant cervical spine fracture. CT scan is showing no results. What will you do next? Do you start directly antithrombotic? No. You do a repeat CTA or digital subtraction if you're not able to identify in next 1 to 2 days. Okay, that is the correct option. Why? Because if we consider the management of a patient with a blunt cerebrovascular injury, what do you do? So whenever you are doing a CT angiogram and if it is negative or inconclusive, you repeat after 24 to 48 hours. Okay. If it is showing grade 1 injury, if it is showing between grade 2 to grade 4, and if it is grade 5. So what is grade 1, 2, 3, 4, 5? So this is a Denver's scaling of the blunt cerebrovascular injury. So grade 1 is basically a irregularity in the vessel wall, or there is some dissection or hematoma with less than 25% of luminal stenosis. What is what is grade 2 injury? So the injury is increased with a intraluminal thrombus, or there is a more than 25% luminal stenosis, that is grade 2. What is grade 3? It is pseudoaneurysm. What is grade 4? It is complete vessel occlusion. What is grade 5? It is simple vessel transection. So now if we consider the management, so if it is if it is grade 1, you just start with patient on heparin therapy and do CT angiogram after 7 to 10 days of starting the antithrombotic therapy. If it is persistent or the injury is still there, you continue the antithrombotic therapy for more 3 months. If healed, then you stop it. If now we come to grade 2 to grade 4, you need to go for management. Either you go for open or you go for endovascular, whichever is available, but preferably endovascular or open. And then again, similarly, repeat CT after week or 10 days. If injury is there, you again continue the antithrombotic therapy for 3 months. If it is healed, then you stop it. And in grade 5, you immediately go for either operative or endovascular management.